Sarika Aggarwal, Pediatric GI, Time for Children's Health. We'll talk about celiac disease, which is a disease under the iceberg. I have nothing to disclose.
Oh, they have the. Oh, where's the clicker? I didn't give you a. But it should. Can it use the arrow?
Okay, so before we go into celiac disease, let's talk about the top wheat-related diseases that we need to think about when we are thinking about anything related to wheat. So the topmost is celiac disease, which is an autoimmune disease. Everybody knows about it. Then comes gluten allergy, which is an IgE-mediated disease. And then a new entity called as non-celiac gluten sensitivity, which is full of controversies. So what is celiac disease? It is an immune-mediated enteropathy that is caused by permanent sensitivity to gluten in genetically susceptible individuals. It's a unique autoimmune disease in the sense that it requires both an environmental trigger, which is gluten, and an autoantigen, which is tissue transglutaminase. And it also requires the person to have HLA DQ2 and or DQ8. The other unique point here is once you get rid of the autoantigen, the environmental trigger, then there is complete resolution of the disease. So before we go into details, let's see what celiac disease is commonly known by. So celiac disease is also known by all of the following terms except any guesses? Sprue gastritis. It's commonly known as celiac sprue, non-tropical sprue. Tropical sprue is the infectious part. Non-tropical sprue, which presents in a very similar way, is celiac disease. And gluten-sensitive enteropathy. Celiac disease can, what's the prevalence of celiac disease among men and women? Is it twice as common in women or than in men? 3 times, 4 times, or 5 times?
3 times.
It's twice as common in women than in men. Close, though. So let's talk about how the celiac is, what we commonly in the GI world we call them as celiacs, present as. GI symptoms is the most classic presentation of celiac disease, though it doesn't involve majority of the patients. Most of these patients who come in with GI manifestations present with either abdominal pain, distension, diarrhea, constipation, nausea, up to failure to thrive, and less commonly intestinal lymphomas can be a presenting symptom. Though I have seen one pediatric patient with this, but according to the literature, majority of this symptom is seen in older kids or adult people. And of course, we talk about celiac crisis, which is a life-threatening syndrome resulting from profuse diarrhea, dehydration, and metabolic symptoms. We don't see this as often anymore. And the most important thing, all of these symptoms get better with gluten-free diet. The other non-GI manifestations, which is not the classic manifestations of celiac disease, but now getting more and more common because we have started screening patients with similar symptoms, include anemia. It is the most common non-GI symptom that can be secondary to iron, folate, and vitamin B12. Having said that, vitamin B12 deficiency is very rare in these kids. It can still happen, but it's rare. And anemia can be a presenting symptom in like 5 to 8% of adolescents and adults with anemia. 10% of the short stature kids can have celiac disease, and around 9% of these kids with elevated ALT in pediatric population have celiac disease. Dermatitis, we all talk about dermatitis herpetiformis, which is the classic pathognomic dermatitis associated with celiac disease, but other things that can be that can present in these patients include chillosis, stomatitis, hyperpigmented dermatitis, acrodermatitis, and that is all these symptoms are mainly due to deficiencies of zinc, vitamin A, and E. Neurological involvement can range from neuropathy due to electrolyte, essential fatty acid deficiencies, and vitamin deficiencies to headaches, epilepsy, and gluten ataxia. There was an interesting case report, just as a sideline, where the patient presented with occipital calcification and epilepsy and was finally diagnosed with celiac disease. So just a handful of patients, but that's something that we have that has been well established. Bone disease in celiac is a very common concern that all of us have, as they can present with anything ranging from arthritis to osteomalacia. Bone pain, tetany, rickets, fractures can be their presenting symptoms, and these symptoms may be the only thing that may be there in our patients. Commonly secondary to vitamin D deficiency and suboptimal calcium intake, but we also should know that around 3% of these celiac disease patients have juvenile chronic arthritis. Majority of these bone issues improve, do not resolve, but improve with gluten-free diet. Dental enamel hyperplasia generally occurs in permanent teeth and may be the only sign of celiac disease. Other presentations include behavioral changes, depression, anxiety, tiredness, exhaustion, delayed puberty, infertility, and then, of course, we always think about refeeding syndrome in some of these kids because they present as really malnourished patients. Majority in the GI population versus any other pediatric population, and of course, they develop secondary lactase deficiencies, which gets better once they are on gluten-free diet for a few months. So, celiac disease, in the old celiac disease that we used to see in Europe, that's where everything or the majority of the celiacs and all this research was done because they had the maximum population. Those patients were described mainly in the pediatric population, and the celiac disease was described as a typical disease of infancy, where basically the entire family had, do I see the cursor here? Do you guys see the cursor? No. So if you look at the photograph on the upper left corner or right corner for you, that's how majority of the families were if they had celiac patients. Very malnourished, young, little ones who probably didn't even survive for more than a few years. But now it is defined as the most common genetically induced food intolerance with a prevalence of 1%. It is around 1 in 133 healthy individuals among the healthy population, and the risk increases in relatives. The risk also increases with the age and gluten exposure, and hence not all kids present within the first few years of life. This is a list of the autoimmune diseases that are often associated with celiac disease, and sorry, how do I go back? And this is a list of genetic disorders like Down syndrome, Turner's, Williams, IgA deficiency. This population is our target high-risk population where we really screen for celiac disease versus test them, in the sense like they don't come to the GI population. They go to everybody else, and that's where they get screened for celiac disease. So talking about the celiac iceberg, the first slide. What is the celiac iceberg? The symptomatic celiac disease patients are just the tip of the iceberg. These are the patients who have symptoms, come to the pediatricians and pediatric GI people, and we go ahead and test them and finally diagnose them with celiac disease, generally present with gastrointestinal symptoms. Coming down, just below the iceberg is the silent celiac disease patients, where they may present with non-GI or atypical symptoms, and that population is often either in the found in patients with high risk. The list that we talked about in the previous slide. Both symptomatic celiac disease and silent celiac disease have mucosal lesions and have positive serology. Coming to latent celiac disease, they may have positive serology but normal mucosa, so they are asymptomatic. They will eventually develop celiac disease. How long they're going to take, nobody knows. So this is another diagram showing that active screening from our perspective, by the pediatricians and the physicians, have increased the diagnosed cases and reduced the iceberg size. Despite active screening, around 50% of these celiac go undiagnosed, and it's funny that most of the symptomatic patients have very low awareness about celiac disease versus the ones with high risk of more knowledge about the same. This graph gives you a similar picture. The big blue towers are basically the overall iceberg, and the small columns are the tips, which are the diagnosed patients. So everywhere in the world, the iceberg is huge as compared to the diagnosed patients. So celiac disease has a very, very strong HLA association. DQ2 is the most common HLA found in majority of the patients, and the rest of the patients have DQ8. just because you have HLA positive, HLA DQ2 or DQ8 positive doesn't mean that you have celiac disease. It is not sufficient. There are other genes and hence that have been, are being identified but not yet confirmed. So lately the inheritance of celiac disease is considered more multigenic versus just a single gene. This slide gives you an idea about how small the celiac population is as compared to the HLA DQ2 and DQ8 population in the big general population. So quickly talking about the pathogenesis, as we talked about in the first few slides, it requires two things. First, you have to have the genetics, and second, you have to have an environmental trigger. So the genetics is the HLA DQ2, DQ8, and gluten is the environmental trigger. But at the same time, you may still not have celiac disease and may require other triggers, environmental triggers like being a female. You have a higher risk. In certain intestinal infections, pregnancy, cancers, several viral infections have similar homology or like a sequence homology with TTG, and that's where they introduce the autoimmunity, and hence the patient develops celiac disease. Certain parasitic infections also create the same homology. And then ultimately things happen and you present with celiac disease. So, so why is this HLA DQ2, DQ8 very important? Because this is what is really required to get a hold of the tissue transglutaminase antigen and present it to the CD4 T cells to create or result in disease and damage. So how do we diagnose these patients? The principles of diagnosis include we have to confirm the diagnosis before we put the patients on gluten-free diet, because the diet is not easy, and once you have confirmed celiac disease patient, you cannot cheat. It affects the quality of life, and if you are not purely gluten-free, it increases the morbidity and mortality of the patients. The most difficult patients are those who have latent disease and silent celiac disease. Just because they don't have symptoms, they don't realize that not eating gluten is going to be beneficial for them. According to the Espigen and Aspigen recommendations, diagnosis of celiac disease require two important criteria. That is a small intestinal, characteristic small intestinal histology, which we'll talk about in a second, and complete resolution on gluten-free diet. Serological tests are basically to help us get to the goal. Monitor the dietary compliance, identify high-risk patients, and so on and so forth. But
so the diagnostic requirement on the silent disease, don't have those. The patient have you don't have pathology, you don't have symptoms.
They don't have symptoms, but the histology is going to improve. They have the histology though. The problem comes in the latent celiac disease, where they have normal histology and just positive serology. But positive serology, if they do, that does get better. So it's a combination of histology, serology, and symptomatology that we look into. And then, of course, there are select cases that need additional diagnostic testing, that despite everything being the other way, we still go ahead and need to score them. So evolution of diagnosis of celiac disease has gone from using anti-gliadin antibodies in 1980s to TTG lately, and now deaminated gliadin peptide, which is a new thing. Still not as common because it's not very accurate, but very, very useful in pediatric population. So this table actually gives us the sensitivity and specificity of the different serological testings, and T2G IgA is the most sensitive test among them. DGP is more sensitive in children than adults, specifically in kids less than 2 or 3 years of age, where TTG IgA is not something that we completely depend upon. Other things, HLA typing, yeah, we sometimes do, and extremely confusing cases like that, high-risk patients, diagnostic dilemmas. Once negative, it has 99% confidence, right? So it's useful when it's well, it may be useful if it's positive, but it's definitely useful in ruling out celiac disease if it's negative. Another quick point on IgA deficiency. There are several patients with IgA deficiency, especially in the autoimmune world, and they do have an increased risk of celiac disease. They are one of the group of patients who cause diagnostic dilemmas because it's really hard to follow their serology, and sometimes all they need is just scope and biopsy. This is a slide showing the different range of the endoscopic evidence, and the celiac. Some may present with completely normal appearing folds in the duodenum to these tiny dips that occur due to blunting of villi, and we call it as scalloping. And some patients may present with endoscopic findings of nodularity and complete baldness is often. That's the terminology that we often use. Histologically, a normal duodenal mucosa should have nice-looking villi. If you look at the normal 0 picture, it has beautiful villi with no intraepithelial cells, which is the bluish hue that you can see in the epithelium. And as the damage worsens, the villi gets shorter and the blueness increases. And the blueness is basically evidence of intraepithelial lymphocytes. This slide gives you a similar pictographic evidence of celiac disease, but it also gives you more information about, just because we have biopsies which represents or which is indicator of celiac disease, we should not blame everything on that. We should look for other things, ranging from infections like Giardia to milk protein intolerance, marasmus, and gas versus host reactions. So how do we treat these patients? Avoid gluten. Easy peasy, right? So what are the sources of gluten in our diet? Pretty much everything, right? A big list, and this list is not complete. That's by no means. Other potential sources are things that we don't think about: sauces, meat products, communion wafers, seafoods. So we have to start questioning certain things, like is this seasoning or spice, does this have gluten? Are we dealing with malt and dextrins derived from gluten products? So once we start thinking about it and looking for it, we start avoiding those things, and that requires a lot of education for parents and families. So the treatment of celiac disease is not an individual treatment. It entirely messes up the kitchen of a household. Other things that we often forget to consider include makeups, shampoos, Play-Dohs, over-the-counter medications, all these non-controlled stuff, which are not supposed to put a label of gluten-free or has gluten in it. So just because you're on gluten-free diet doesn't mean that you are very healthy. This is the latest in thing. Everybody is saying that, hey, I'm on a gluten-free diet, I'm leading the most healthy life, which is apparently not true. When the patients come in with gluten-free diet, we worry. So, and this is why we worry, because now they are getting majority of their calories from starches and fat. They're going to land up being obese, and then if not now, then in the near future. They have tons of vitamins and mineral deficiencies and fiber deficiency. Now that they're gluten-free, they can still get constipated because they have no fiber anymore, right? Most of the processed food or packed foods don't have as much fortification as the wheat counterparts, but these can be managed if we have to, by careful planning and proper education of the patient and family. And it's surprising that we were actually not born to eat gluten, not everybody in the entire world has celiac disease either. It's only a very, 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 very small percentage. And grains and gluten came into being only 10,000 years ago when we started doing agriculture. So, but it has taken a huge place in our diet now, and it's hard to replace it. This is a list of gluten-free grains, and one of the ways that we recommend replacing regular wheat, rye, and barley, using buckwheat, using amaranth, millets, corns, all these flour nuts, beans, flour from seeds, and these have a lot of nutrition and fiber in them. But of course, we have to make sure that they are not contaminated. So once diagnosed with celiac disease or once on gluten-free diet, we have to supplement them because it's hard to get all these things in place. We need to make sure they're having adequate vitamin D, adequate calcium, folic acid, and sometimes we just decide on placing them on multivitamins along with other things. We do closely monitor all these levels every year, initially every 6 months and then every year. So just because you're on a gluten-free diet in a celiac patient, they can present with other more common things and other more common causes of GI symptoms, which could be present in any of the other patients. And these include, food allergies, acidic foods, certain flours, beans and nuts that are more gassy, and, food intolerance, rapid increase in fiber intake and not keeping up with their fluid intake, and, of course, antibiotics. So let's talk about some interesting points, which I didn't know where to fit in, so I'm just going to say that. Mucosal, just because you are on gluten-free diet, doesn't mean that you have mucosal recovery, and we'll talk about it in one of the last slides. But mucosal recovery is equal to response to gluten-free diet. 95% of the children have mucosal healing within the first 1 to 2 years, and hence once diagnosed, we tend not to scope them unless we have to. Patients on gluten-free diet create the biggest diagnostic dilemma for us. They don't want to go back, and it's super hard for us to tell them what to do next. So when we encounter this, we just say, go ahead, start gluten. 50% of them will say, okay, and 50% will say, no, you're not in your right mind, and maybe we'll just go ahead and see another GI physician, which is fine. But basically, in pediatric population, you need more gluten exposure for a longer period of time to create the same damage for a diagnostic purpose as compared to in adults, where you can be done with, or adolescent adults, where you can be done with 2 slices of bread for 2 weeks. So more torturous, right? So how did government think about these patients? They came up with gluten-free labeling rules back in 2013, where everybody in the food industry had to label their foods with these prohibited grains. If they're gluten-free, labeled as gluten-free, they should not contain wheat, barley, rye, and cross-contaminations either. They shouldn't contain ingredients derived from these grains, and if they do, then it should be less than 20 parts per million in the entire process, in the entire packed food. And you can only label food gluten-free if it has less than 20 parts per million. That's the website that you can actually go into to get more information about this. Before 2013, in 2006, Food Allergen Labeling and Consumer Protection Act came up with the rule of labeling every food with the 8 most prevalent food allergens, which include egg, fish, meat, soy, peanuts, tree nuts, shellfish, and wheat. It did not say anything about barley and rye. They had to list all ingredients in their products, but it did not include, as I said, barley and rye. It didn't include meat products, even though they try and manufacture in a more controlled manner, and it did not include any over-the-counter prescription medications, or prescription medications, sorry. So as evolution of gluten-free diet has been rapidly progressing over the last several years. In the last 10 to 15 years, there have been several phone apps that have come in, and they not only identify gluten, but some of them actually identify pretty much every ingredient. So if you want, you can keep scanning all the barcodes, and you will know what they have. Yes?
Question. You go in a supermarket now, and long aisles of gluten-free food, and even regular food. Cheerios has been relabeled with a big font, gluten-free. People, especially women the world over, know, they may not know celiac disease, but they know there's gluten is bad, and they put themselves on gluten-free diet, and many of them without celiac disease do indeed do well. Do you think that this is affecting the diagnosis? And these young women are probably going to feed their kids gluten-free diet. Are we doing good, or are we missing diagnoses?
I think this will create more diagnostic dilemmas and missed cases, just because the exposure is not going to be as much. The problem with these is when you start doing gluten-free packed food, and you don't have the education about the real gluten-free diet, you don't look into other things, number one, all the other contaminants, and number two, you don't think about all the nutritional deficiencies that they will create in themselves as well as in their family.
You think we're keeping you guys from making the diagnosis on a lot of people?
That's always better. So just so that, we can rule out celiac disease. And then once celiac disease is ruled out, they can, decide on their own, because half of the population now has IBS and they respond to gluten like any other FODMAP diet, right? So gluten tester, the in thing, and one of my patients actually told me about it. So it's a great thing where you take a piece of food, put it in this, this triangle thing, and it does some kind of chemical reaction and tells you whether this thing is ready for eating or not, or it's gluten-free or not. It detects gluten as low as 1 parts per million. The problems are it's extremely expensive, and we don't know if we really need to detect gluten at that low level either. And then, of course, it brings out the question of quality of life, like you can't eat here, you can't eat there, you're carrying your own food, and then more and more issues to come. So quality of life in these patients with gluten-free diet include their socioeconomic activities. It's a very difficult diet to follow, very different from everybody in the world, very uncomfortable, restrictive, not as tasty or flavorful as a lot of patients tell me, but they're getting better, of course, right? The other day I accidentally ate a gluten-free cookie and it was good. So, so they're working on it. It's hard to follow and very expensive if you're buying it up, in the supermarket, 3 to 5 times more expensive than the wheat counterparts. And, all these, it has nutritional deficiencies, and everything taken together forces these patients to cheat in hospitals, restaurants, schools, dorms, colleges, and then they don't want to be different from their friends, right? Especially in the pediatric population. Once you grow old, nobody cares about it. And of course, it's not as easily available unless you're living in a big city like San Francisco. Yes, it has definitely changed in the last 10 years I've been in the United States. So I've noticed the difference. So just a quick word about non-celiac gluten sensitivity. It was first identified in 1980s. It is characterized by GI and non-GI symptoms with gluten ingestion, but they do not have the serological markers or the biopsies or gluten allergy. And patients, the only thing that we can pinpoint on is that patients report response. It's a very, very tricky thing that we need to look for, that is because its response is very similar to the low-fat diet. So basically, if you don't eat anything, you're not going to have symptoms, right? So in other words, the other thing is it's still a very controversial diagnosis. There are people who swear by it. There are gastroenterologists who say that this is definitely an entity, and there are people who say like, oh, this is just another portion of IBS. Okay, so let's play now. Okay, few questions here. What circumstances may trigger celiac disease? Eat. Perfect. People were listening to me. People with celiac disease often have which other diseases? Okay, very good. Celiac disease originates as a result of combined action involving. This is a tricky one. Should we lock it? C? D? B? A? Okay, it is D, the adaptive and innate immunity. So you need the environmental trigger, gluten, that creates the adaptive, and then you have to have the innate immunity in place too. So a close association between celiac disease and type 1 diabetes may be due to B. Very good. And then all of the following about refractory celiac disease are true except. This is a hard one. B? B? Very true. So, quick word about this. Refractory celiac disease happens in around 10 to 15, 18% of these celiacers who respond to gluten-free diet really well for the first several years, and then they stop responding and start having these same exact symptoms as they presented with, or sometimes even worse. And in these individuals, the treatment finally we have to resort to immunosuppression. So topical steroids or systemic steroids, and sometimes as far as Remicade. But those are like really handful of rare cases, and we don't see, we just dump it on the adults, right? Happens after they graduate from us. Okay, any questions?
How do we make the diagnosis with patients who don't have any symptoms?
That's very hard. Majority of the diagnosis happens, as we talked about, in that tip of the iceberg where they present with real symptoms, that is the GI symptoms, and then the rest is basically suspicion. So if a patient comes in with repeated fractures, you do the Celiac. The patient comes in, oh, he's problems with fertility, problems with, dentists diagnose them, neurologists diagnose them, hematologists, and basically, and of course, they come in with certain vitamin deficiencies, and you're like, oh, maybe we should do this. So suspicion of the disease needs to be very high.
So just to clarify, because you alluded to it on your slide, but so you have I'm general patient. So you have a patient, they have been diagnosed with celiac, they have a bunch of siblings. So a mom and I were just talking about this. So we can screen them with the TTG, IgA, and IgA every couple of years.
Mm-hmm.
At some point, do we just do the DQ, and then if they're negative, we stop screening them?
You could. It's just another $10,000.
So does that get covered by insurance or no?
Mostly no.
So that would be the reason not to do it. But if it were covered, that would be a very reasonable screening strategy, that if they were negative, we didn't have to keep testing.
Sure. Yes, that's it. Exactly.
Okay, perfect, thank you.
But of course, if it gets positive, then you don't know what to do about it.
So if it's positive, then you keep screening, I guess. So if it was like, say it was a $10 test, like it could potentially eliminate a lot of blood draws for kids who don't like some blood draws who are asymptomatic. But,
True. For the kids with the Down syndrome, what's the guideline to screen celiac disease? Once or every how many years?
I generally, initially for the first few years, I screened these kids every year and then spaced it to every other year.
So do you do the HLA one time? Just the Pedi?
Unless they're symptomatic. HLA, I do HLA only in dilemmas like high risk. Sorry, I don't.
oh, I'm Lisa.
Please. Okay.
But if they're HLA typing negative, then they don't have a.
Yes, if it's negative, then we don't have to
You don't have
worry
to say
about it.
they're screening anymore.
We could. Majority of them, I think, are Medicaid covered, right? So if the insurance pays for it, it's not a bad option. The problem is,
Negative, then they don't have to do it anymore.
yes, but the problem is like with all these autoimmune and genetic diseases that have strong correlation with the celiac disease, they may still have the HLA haplotype. So if we screen them and if it's positive, we just keep screening them forever, and it gets easier if you're on G-tube feeds because a large portion of these formulas are all gluten-free. So, but it gets difficult when these kids are poorly fed and they have only like 5 things that they eat.
And also, there's the parents try to use a gluten-free diet for somebody who has autism, Asian
Yeah, yes,
disease,
that-
or something. What is the updated information?
So a lot of developmental people are doing gluten-free diet in autism, and and then the problem is like some parents just swear by it. You can't do anything, and who knows whether that swearing is because they saw symptomatic relief being on kind of a FODMAP diet, because everybody gets fixed with everything in the GI system when you are on FODMAP diet, right? Which is pretty much like a very, 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 very limited diet. But it's hard for nonverbal patients to express their discomfort and parents to understand that this discomfort may or may not be due to gluten. And then the other problem with those patients is that they just get rid of the gluten. They don't screen every little thing. So if they do land up having celiac disease, it gets really hard to diagnose them. And then, of course, it's all the other things that come with it, and then nutritional deficiencies and stuff.
If you have an asymptomatic sibling who's positive serology, do you scope them?
Yes. And the main reason is because they probably may be falling under the category of the silent celiac disease. So let me show you this slide real quick. So basically the slide of the ice, just below the portion of the iceberg just below the tip. Of course, I don't know of an easier way to do this. So they'll probably fall under the silent celiac disease, which is the group of high-risk patients. Uncommonly, they may be in this latent celiac disease, and then it's just a wait-and-watch game.
So how many of those kids who fall into that category when you do endoscopy are normal versus pathology? Just out of curiosity, off the top of your head.
I've had only a handful of these patients. probably because my years of experience is less as compared to many other experienced peds GI, and I'm sure they can attest to seeing way more patients and requiring longer period of diagnosis in these patients. So some patients just require more than one scope to diagnose, especially in high risk. If they don't have any high risk thing, then we like, okay, maybe we should not screen them anymore. But once the serology is positive, we like the serology to get negative or the biopsy to get positive. So.
Thank you.
Thank you.
Thank you.
Thank you so much for coming.